kind words. It's great to be back in Bangkok and at Siriraj. I appreciate the invitation from Dr. Sata and to see good friends again, Dr. Shin and others. So really my goal today is to give kind of big picture, the idea of, not just trauma education, but trauma education as part of a system of care for trauma, and, the need to be able to focus on the basics. My background is in cardiac arrest, but it's the same idea, taking care of a patient from initial collapse, whether in cardiac arrest or initial injury. All those steps that happen in sequence after really will determine often, the likelihood of that patient's morbidity, mortality. And I think trauma is no different than cardiac arrest. It really does take a system to care for a patient, particularly if they're, critically ill, with significant trauma. I will say it's been great to visit here again too, because the other day we were at the MS Center, and I was watching a recorded tape of a physician interacting with field providers using telemedicine, right? So cutting edge technology and a lot of things that have changed just in a short amount of time. So it's great again to be back here, and look forward to the discussion. So there'll be time for questions at the end. This is my outline, again, for the lecture. As I mentioned, you're going to talk about a system of care approach first, what we call a framework for a learning trauma system of care that's evolving over time, continually changing, not being static. And then obviously the focus on team-based approach and using simulation as part of trauma education. And then a course that has been developed by colleagues of mine at Emory University, as well as colleagues in Indus University in Karachi, Pakistan, that we've been working on more recently. The article you can see here, I think, is just a good summary, a meta-analysis looking at the benefits of developing a system of care approach or a trauma system, particularly in countries or communities where it doesn't exist. When they implement or insert a trauma system of care, there's clear evidence to show morbidity and mortality will go down. And then as the system matures, there's even greater benefit. So this idea that putting a system of care approach in really does make a difference. Sometimes it's hard when we think of one individual patient at a time to see, like, do certain things make a difference? You have to look at the bigger picture to really see that. And this is a common theme when you look at some of the literature is, it's easy to show when you make changes that you can see process measures, right? Did we get the patient to the operating room sooner? Did we get them triaged sooner? That's easy to show. The actual clinical benefit is sometimes harder to show, but when you have a larger system, and again, you have data in a database, that's where you can begin to show these differences. So again, a common theme of being able to make changes at an institutional level arguably will translate into clinical benefit, even if it's hard to show that in your own hospital. The slide here, I think, is a good explanation. We think of cardiac arrests, we think of what's called the chain of survival. You could argue that the links in this chain here are really no different in a system of care approach. From that moment of injury, what actually happens? Do bystanders call for help soon? Do they hopefully provide bystander care? The EMS response, the hospital response, and then the post-hospital response. Each of these links being very important in terms of the patient's morbidity and mortality, but also thinking prior to the event, could we have prevented this event, right? Injury prevention, we'll talk about that. And again, the importance of data, having a trauma registry. It's great to know locally here, there's been investment in collecting data. Dr. Shin is responsible and others for developing PATOS, or the Pan-Asian Trauma Outcome Study. So we'll talk a little bit about that, the need to have information to be able to understand, how are you performing, how, not just the incidents and types of trauma that you're managing your system, but understanding how to use that data to improve care. And again, when you think of injury prevention, there's a number of different models out there, but just something as simple as, focusing on fall prevention, right? We know when patients get older, that's a fact of life, there's a greater chance of fall risk. How can we make the patient's home safer? How can we prevent some of these events from occurring? Violence prevention, of course, substance abuse issues, traffic safety. And I'll give some examples here in just a minute. Picture here is real. I know this doesn't look real. Any idea where this might be? I'll give you a hint. It's in Asia. What country do you think this is? It's not Thailand. It could be. Any ideas from the audience here? Indonesia is a good guess, but Vietnam, nope, but closer. It's Philippines. So anyone know a nice place in the Philippines, a very popular beach? Boracay? Yeah. So this is actually Boracay Beach. And this isn't my picture, but pretty close to where this picture was taken. I was there almost 4 years ago, because remember it was Easter week 2019. I was visiting. And the reason I show this picture is it looks like paradise. And while I was there, I was sitting down for lunch and I hear someone yell CPR, CPR. And I'm like, okay, so I put my laptop to the woman, the server. I'm like, hold on to this and my phone. And I run down the beach and they're pulling a person out of the water. And I look at the guy and I can see he's awake. But the first thing I notice, he's not moving. And it's because he was doing cartwheels down the beach into the water and broke his neck. So very sad. So I'm basically providing first aid, stabilizing his neck. EMS comes, he eventually goes to the hospital. The question I had to the providers was, how long was he going to be on the island for? A very small island, because they're not going to be able to manage this. They said he would get on a boat and then 2 hours later, regional hospital. Next day, I found out he died. He died at the hospital. He never left the island. So it really wasn't a system of care to get him what he needed. He needed a higher level of care. He likely developed cord edema and, had a respiratory arrest, is my guess. He never got intubated. So this is paradise, but this is reality, right? You need a system of care, even when you're looking at a beautiful place like this. That was Sunday. Monday, there was an earthquake in the Philippines. So it was a bit interesting trip. And does anybody know where this is? I'll give you a clue. It's in Vietnam. Okay, this is Quang Kim Lake in Hanoi. This is where I was living in 2019. So the next day, there's earthquake. My flight gets delayed. I come back a day late. I come in late at night near here. I live near this lake, very close to the lake. And as I get out of the cab, I'm like, what's going on? There's a crowd of people. And then I realized what was going on was 2 teenagers had been riding a motorbike around the lake very fast, no helmets, fast at night, and hit this tree. So I called my friend who was in charge of the ambulance service, Dr. Tang, and he picked up on the first ring at 1:30 in the morning and said, are you okay? I said, I'm okay. Can you send 2 ambulances? Because he knew where I lived. As we're talking, the first ambulance comes. Put the first patient in the ambulance. He goes into traumatic arrest. The hospital's a few hundred yards away. Next patient was under the motorbike, pulled the motorbike off. He died a few hours later. The reason I give this as an example is trauma care is not going to help these patients, right? These are preventable events. There's nothing to do when you have that severe an injury. What you can do is focus on traffic safety, speeding, substance abuse, helmet. And there's been changes in Vietnam as in other countries, enforcement, changing law, education. These are the types of things that would only help a patient like this. You have to prevent this injury because it's a fatal event. The care is not going to matter. So I was very happy to be back in the hospital the next day because I went away for the weekend and I was like, it's very dangerous out there between the Philippines and Quang Kim Lake. And again, this is an example. This is a picture from Ho Chi Minh City showing, trying to educate the public and an enforcement message, right? Don't drink and drive. I think the penalties there have changed in the last few years. So people are paying attention more carefully and trying to avoid, again, from an injury prevention standpoint. Next ring, talking about bystander care, right? Being educating your community. Those first few minutes, we know the first few minutes and the care that occurs in the pre-hospital environment or the patient with significant traumatic injury, that's the window and that's the environment that we're most likely going to be able to impact the patient's outcome. Obviously, care in the operating room, care in the ER are very important, but those first few minutes of doing basic first aid often can have the greatest impact in determining whether that patient actually arrives at the hospital alive or is discharged later from the hospital. Pakistani Lifesavers program that began back in 2020, I'm familiar with, really trying to train 10 million Pakistanis on basic first aid, hemorrhage control, and compression-only CPR. On the right, you see Stop the Bleed, educational program in the US, trying to educate the public on what to do in those first few minutes. Again, an ambulance or a first responder getting there is very important, but that's still going to take time. And if you're not providing any pre-care to that patient, pre-arrival care, often the outcome can be very different. When we think of the pre-hospital component, basic trauma life support is an example of a course. There's other courses out there that can train pre-hospital providers in managing patients in the pre-hospital environment. The analogous course in the hospital we think of in the US is advanced trauma life support. I'll talk about the CATC course I mentioned earlier, but the idea of having standardized training in the pre-hospital environment, standardized training in the hospital environment, the importance of triage, and again, getting the patient to what they need. If a patient has a significant injury, you may not want to go to the closest hospital. You may want to go to the closest appropriate hospital, a trauma center that's set up and available to manage that patient. That, again, is a part of the system of care. Notifying that hospital. 5 minutes notice is an eternity. It's a large amount of time that you can get people out of the operating room to come down to be ready for that patient when they come in. So EMS really has, of course, a really important role, but the communication and the coordination of care are very important. And obviously the handoff, that transition, really important. This is a report that came out of US several years ago from what's now called the National Academy of Science, and really is focusing on the importance of a trauma system of care and these links, like I've just mentioned before, emphasizing that the greatest opportunity to save lives is actually in the pre-hospital environment when you look at conditions. Basic first aid makes a difference. Surgical care is important, but if the person is bled out, it's too late. If they don't have an open airway, just managing simple things can make a difference. And the idea that there needs to be greater coordination. So a lot of this came out of the report, but also the idea of using formalized triage guidelines. And again, there's a number of different ones out there. This I pulled up more recently. This is American College of Surgeons. They updated guidelines in 2021, suggesting in a pre-hospital environment, field triage, which patients are most deserving of a highest level of trauma care versus which patients should probably go to a trauma center, but not necessarily the closest. And the idea that this is based on expert opinion. And examples here, right? Patient with significant penetrating injury, that head, neck, or torso. Patient has an amputation. Patient has a significant pelvic fracture. These are patients that are high risk for developing mortality. They're going to benefit from going to a higher level of care. Looking at vital signs, again, so some of it's based upon presentation, others based upon physiological data, right? And looking at based on age, blood pressure, and pulse rate, using that to guide your criteria. Moderate or serious, again, this list is here to provide guidance. Looking at mechanism of injury, significant mechanism of injury, you're going to have a much greater suspicion. And then judgment, right? The pre-hospital provider makes that judgment. So that communicating, appropriately triaging the patient, bringing them to the right facility and calling ahead, that alone can make a big difference in terms of the care or the likelihood of decreasing morbidity and mortality. At the hospital, we think of a trauma team, right? A trauma team doesn't happen by magic. It happens by organizing and training nurses, physicians, anesthesiologists, technicians, all to work together in a coordinated approach. And that's part of the training that I'm going to talk about in a bit. We've presented an approach to not just learning how to manage or how to perform a primary and secondary survey and initial stabilization, but how should nurses and doctors, not only because they're going to be working together, that they're training together and using a trauma team approach, we believe makes a difference. Post-hospital care I mentioned earlier. I think this quote here kind of sums up on the importance, right? It's not just getting the patient to survive to discharge to go home, but that they can go home and get back to their life functionally. Really important that the rehab component piece be part of a trauma system of care. I mentioned PATOS before, and I'll mention it again, Dr. Shin and others that helped develop this. Data collection is not sexy, but data collection arguably could have greater impact in terms of saving more lives when a system is consistently looking at who are we taking care of, which injuries do we see a lot, how might we use that data to make decisions about prevention, but also performance, from a quality improvement standpoint. If you don't have data, we would say you're flying blind. And again, the system here recognized that several years ago and has been collecting data now, I believe, for three plus years. And I think using that data to begin to make decisions, very important. Not sexy, but key and really important. Obviously, measuring the incidence, what type of injuries, the outcomes, the risk factors of, who are you seeing in terms of their comorbidities, and then again, measuring the performance of the system, pre-hospital management, hospital management, post-hospital care. I'll mention as a metric, I work with other physicians managing our helicopter system. One metric we look at very carefully and have for years, scene time. We have a significant trauma patient. How long are you on the scene for? We want to see ideally less than 10 minutes. And if it's over 10 minutes, we definitely want to look at that case more carefully to say, was there other things that prevented? Because we know time matters, and definitive care, again, initial care, very important, but getting that patient to definitive care, really important. And the longer the delay to the definitive care, we know often the outcome is worse. I think everyone recognizes this. These are scooters. When these first came out in Atlanta, where I work, we noticed the pattern, right? We were seeing a lot of patients with injuries. No one was wearing a helmet. Like, you'd wear a helmet for a bicycle, but you wouldn't wear a helmet for a scooter. But what was noticed in data early on in our own trauma system was that there were a few the initial fatalities had a common theme. They all occurred at night, and they all occurred when somebody was on a scooter getting off a sidewalk, crossing a street, and got hit by a car. So that information translated back to the city council changing a law saying you can't ride a scooter at night and you shouldn't be crossing the street. Shouldn't be riding on a sidewalk. So again, using that information, you can use that to affect policy and hopefully prevent significant morbidity and mortality. So there's a report that came out in the National Academy of Science back in, this is almost 10 years back, a report on a trauma system of care approach, and really talking about preventable deaths, not just preventing injury, but the idea once the patient's had a significant event, is the trauma system set up to make sure that that patient survives? And we believe there's somewhere around, this report believes there's around 5,000 or 6,000 patients a year in the US that likely could have survived if they were provided with a good care. And there's a lot of variability depending upon where the patient would end up. There's a short video here that I think does a great job of summing up not just the burden of disease, and again, this is US specific, but the idea that if you put a system of care in place and you have goals and objectives to make sure that care is superior, that you can actually save thousands of lives. I'm going to see if this plays here. It's about 2 minutes.
You may not think of it as a public health issue, but did you know that trauma is the leading cause of death in the United States for those aged 46 and under? Traumatic injuries occur every day from events such as gun violence, car crashes, and falls. Multiple casualty events such as those in Sandy Hook, Boston, and San Bernardino have increased in frequency. Since 2001, approximately 2 million Americans have died from trauma. Roughly 1 in 5 deaths from trauma, or 30,000 per year in the U.S., may be preventable if appropriate and timely medical care is delivered after injury. Yet there is great variation in the quality of trauma care and outcomes for injured patients across the United States. In fact, the chances of dying can vary as much as twofold depending on where you were treated. In other words, where you were injured may determine whether you survive. Innovations in military trauma care, such as redesigned tourniquets, have contributed to unprecedented survival rates for service members wounded in Iraq and Afghanistan. Translating military innovations and best practices into the civilian sector could help save tens of thousands of lives in a single year. Patients and the public can help to improve trauma care. In the initial moments after an injury occurs, you as a bystander can deliver immediate life-saving care before EMS personnel arrive. If you have been seriously injured, be engaged in decisions about your care as much as possible so that providers can consider your preferences, life circumstances, and values. patients, families, and other caregivers can participate in processes that work to improve trauma care, including trauma research. A report from the National Academies of Sciences, Engineering, and Medicine says that zero preventable deaths after injury and best possible recovery is an achievable aim to benefit those the nation sends into harm's way in combat, as well as every American. Learn more at nationalacademies.org/trauma care.
Not going to play.
You may not think of it as a...
There we go. Perfect. Part of that report talked about a framework for learning trauma care system, meaning you can't be static. You have to continually change the education of your providers, doing continuous quality improvement, having ongoing access to data, digital environment, but putting the patient at the center of this. And the idea is that this is something that needs to continually evolve over time. You can't just come up with a system and be static. You need to evolve and grow over time if you want to provide the best possible care to your patients. Two reports, these are earlier, I think really important to point out as good reference documents. This is looking at obviously not just the US, but the WHO, which where a lot more people live. One is centered on pre-hospital trauma care systems. The other, the guidelines for essential trauma care. The pre-hospital document I know very well because one of my colleagues, Dr. Scott Sasser, was the lead author, and really focusing on the differences in approach. Not everyone is going to have the same amount of resources, right? Every country, there's different amount of resources, different amount of educational opportunities. And if you look at these reports, they give you a good framework for how would you begin to develop a trauma system. And when you look at different types of hospitals, not all hospitals are created equal, right? We're at a tertiary care center here, very different than a community hospital, right, in the rural parts of Thailand. But there's an opportunity at each facility, whether it's low resource or high resource, to adjust your goals and to really look at how do you provide the care that the resources allow for. And I think reminding ourselves that, trauma is the leading cause of death in low and middle income countries. And again, when you make some basic changes, you can improve a patient's outcome. So you can't obviously provide the same level of care at every facility. That doesn't make sense. Resources don't allow for it, but you need to adjust. And I think these reports do a very good job of suggesting, if you improve and coordinate care, you can make a difference and you can reduce mortality. And this is sort of the hierarchy to it, right? It depends on the amount of resources you have at your facility, the educational resources, and obviously the ability to do quality improvement. It's going to vary. And they break up, from a basic hospital, almost like a clinic, to what we call a general practitioner hospital, a specialty hospital, tertiary care. There's going to be a gradation of educational opportunities and resources that are available. So from a basic hospital, you'd have with basic resources, you'd want to focus on, the basic care. WHO has a basic emergency care course that could be implemented, collecting some trauma data and being able to use that to affect change. Higher level, specialty hospital, you're going to have obviously more resources, more training, and being able to implement that, but also doing more dedicated quality improvement, focusing on morbidity and mortality, and really developing a true trauma registry. Up to tertiary care, where again, more resources, trauma team system development, should be doing trauma team training, and really having a much larger approach. Likely that tertiary care hospital is going to be in charge of a region, hopefully regional data. Again, kind of like what's been happening here locally of working together with collaborating hospitals, using PATOS as an example. Again, some of the literature really does support what we're talking about, the idea of when you implement a trauma team training course, does it actually impact clinical care? And again, as I mentioned earlier, process measures are easy to show. If we do this educational initiative, train nurses and physicians together, we can get the patient to CAT scanner sooner. We get the patient to the operating room sooner. easy to show that, harder to show that there's clinical benefit. But the assumption is we know those things are good. Delays we know are not good. So that's often the tricky part, is being able to show clinical benefit. But large registry type data, that's where you're going to be able to show it. Harder to show at an institutional level. Same thing with systemic review, looking at the role of high fidelity simulation in acute care settings. We know that that this does, again, help with process measures, harder to show clinical benefit. But we have to kind of read between the lines. We believe avoiding delay is a good thing. We know delay is bad in trauma, so we have to assume that this is a good surrogate marker, even if you can't show the clinical benefit at your own institution. So again, a lot of literature here that suggests that there's data to back up using simulation as part of education and a team approach rather than piecemeal. That's essentially what this course came about for, the collaborative course. Or collaborative advanced trauma care course. I work at Emory. I also work clinically at Grady, public hospital in Atlanta. Colleagues of mine, Dr. Anna Yaffe in our department, has worked with colleagues at Indus Hospital in Pakistan. A lot of the same issues in Vietnam, where we first did the course that I was familiar with, as in Pakistan. Not HLS not available, and not really a system approach or a team approach. And that's really what this course was trying to fill in. These are the two first classes. You can see the one on the left was in Hanoi back in 2019. The course in Karachi was a little bit earlier than that. And really working collaboratively with nurses and physicians and focusing on a team approach, and really making sure that people understand it's not just, again, initial primary and secondary survey and stabilization. The ATLS part of the course is important, but it's also team building, working together, training together, doing simulation together, and actually doing a mock drill. I'll show you some pictures here. Why is this important? Because we know we look at mortality in trauma. We know, again, those teenagers that hit that tree, they died not instantaneously, but pretty quick after the accident. A lot of patients are going to die initially in those first few minutes. More patients are going to die, or other patients are going to die, delayed. That's where we know there's an opportunity, where a team approach and a system of care approach can influence outcomes. And this idea of a delayed curve, there's an opportunity to intervene for certain patients. And I mentioned earlier the goals, really education and the team approach. This is one of our nurses teaching the nursing side of the course. So we do the training together, different rooms, and then we come together for certain activities. Team building exercise here that you can see. That's not a great picture, but just to prove I was there. And again, this is not unfamiliar to the group here. When you have a patient, a multi-trauma patient, and you've got a team approach, individuals having predefined roles, training and practicing and simulation in advance of that patient coming in, really helps that team effort, because it does take a team to manage a significantly injured patient. As you say, trauma is a team sport. I think in the interest of time, I'm going to skip through this, but we have a video here that kind of shows part of the education of walking through doing an actual primary and secondary assessment and training in the ER. Surgical skills is a big part of the course. Again, and then simulation, and actually practicing in the ER. So actually taking a mannequin, not a real patient, but going into the ER environment and simulating a patient coming in from the field. And then collecting metrics before, after, looking at knowledge assessment, looking at teamwork, looking at efficiencies. We could see differences when we measured this. And the course has evolved to date. There's been 3 here, but I think there's been 6 courses in Pakistan. We just did a second course in Vietnam, and then Ethiopia. And then we've developed it into a hybrid course since COVID, because everything changed with COVID. There's a pre-course that's online, and then actually to focus those 3 days that we're together, it's all hands-on, surgical skills, simulation, and being able to do mock drills. And then the last day, the 4th day, is we do train the trainer. And the idea is to sustain this. So, and I think just really, kind of breaking up to, I think, the more important question, because we're leading a discussion here. The experiences that people have in your own system. I know we've got audience here and some online, every system is different, or every community is different. Countries are different, resources are different, but having a framework and fitting that framework, and again, those resource documents we talked about, I think those are good places to start if you're working in an environment where there's not an organized trauma system of care, and recognizing what do your resources allow for and where might you start. And if you start with the basics and start with things that you can do, over time, that system can mature. And again, there's plenty of data to show when you develop a trauma system of care, not only do patients benefit, again, morbidity and mortality improvements, but as that system matures, you're going to see even greater benefit. But I'll stop here to talk about, I think, leading into the question session.
Thank you, Dr. McNally. So any question from the floor or online? For those who are in the online, you can put your question in the question box and I'll ask all the speakers directly. Or anyone here, you can ask in Thai and I'll try my best to translate into English. Any question? So I've got one. Got one, Dr. McNally. So I think it's easy to start with physicians. We have the data, we have all the information, but in the real life, in real practice, you said that trauma care is a sport team. So in many systems, those who take care of patients in the pre-hospital, they are firefighters, they're policemen. Some of them might not be medical personnel. So how do you get them? What was your idea to get them involved and improve the trauma care system?
That's a great question. I think, there's definitely that's an issue that we see in many communities. Even where I worked when I was in college, I lived in a fire station and there was a change in culture. The firefighters that were professional, we were volunteer. Professional ones were like, I signed up to be a firefighter. I didn't sign up to do medical care. And over time that changed because they realized the majority of their calls were actually EMS calls. Leadership changed. I think you need to look at current generation and look at, where you need a transition of making this part of their actual training as they come into an organization. It's hard to change when somebody already has an established role to say, nope, now you got to do this too. It's not impossible, but working with the younger, the new recruits, working with leadership to show examples. And I think making sure they understand at the end of the day, first responders, if they don't have the medical training, it can add a lot of value. It just may take several years to gradually put that in. You can't do it overnight. And I think that's it. Looking long-term is probably the advice I would give. It takes some time, but great question.
Online question.
Okay. So we have an online question. Do we have similar 10-step system to help country or region to develop a trauma system like GRA 10 steps?
Oh, wow. That's a great one. I don't know that we have exactly 10. I think those 2 resource documents would tailor to the needs, but it's a good suggestion. Maybe something Patos could consider. Punting it to Dr. Shin. Great question.
Do you have any suggestion on the minimum of the trauma team? Because the problem that faces in Thailand is there in other hospitals that not as big as Siriraj Hospital. Sometimes there are small people in the night shift.
Yep.
So if there are any minimum requirement or minimum person that have a suggestion, maybe we can easier to form the team to provide the trauma EMS and also trauma team standby in the hospital.
Excellent question. And this question comes up a lot, and I think I have a good answer, but tell me what you think of this. So a team can't be one person. So it's got to be 2, and that might be all you have. It might be 1 physician, 1 nurse in a rural hospital. Usually in a lower resource setting overnight, usually physician is there's going to be less physicians than nurses, so typically we would say, if whatever you normally have, your staffing, that's how you're going to need to train. So team would be at least 2 people. If it's more, or you can recruit somebody from upstairs in the hospital to come down, that might be another model. But that is what we talk about in this course. We're teaching a lot of these courses in tertiary care hospitals, but when providers go out to a more regional, 1 level removed or even 2 levels removed, we know that the staffing is going to be very different and the team size has to adjust. So it really needs to adjust to what your hospital could provide for, depending on the time, like at night. And I think what you need to do is to basically define what do you think is the minimum that you'd be able to provide for, and then train accordingly. But it should be at least 2 people, because a team of 1 is stressful.
Yeah, I very agree with you. And the another big problem is there. Sometimes we have a circulation of the people that we are trained. Sometimes there are many people come and and non-professional to do in their trauma care, something like that.
And I think I know what you're asking about. So ideally, if in an institution over time, ideally anybody that's working any shift should go through the same training. So even if it's different people on that shift that haven't worked together, they know the basics. And we know that when you walk in an emergency department, every shift is different, different nurses, different doctors. Often they've not done training together, but if they've done trauma team training and they understand the concept, they understand the role approach, it should be the same. And I think if that, the idea that you have to assume that you're going to be working with people that you've not practiced together as a team. Other hospitals, that may be the case, particularly if it's lower staff, that might be the same staff or less people that they've had a chance to work with previously. But you need to be able to work independently with any other team member. The assumption is that everybody's gone through that training, then all the nurses and all the physicians. So that's the best way to get around it. But great point. Every day it's a new team. It's like a new experience. But if everyone has the basics down, they should understand their role. You can also obviously do debriefing, or at the beginning of a shift, talking about, okay, who's going to be team leader on this shift? Each of the roles, if it's 3 people, what are those 3 roles going to be? Predefined, so everybody understands in advance. That's something that can be done on any shift. So there's less confusion, not just deciding when the patient comes in who's in charge, but actually who's going to be the recorder, who's going to be doing the primary and secondary assessment. Again, it depends on how many providers that your team is made up of, but defining those roles in advance or at the beginning of a shift. Checking your equipment. That's often what we do, checking our equipment. That would be the time to talk about. A lot of places will have a marker or a board saying like, who's the team leader today? Who's the charge nurse? You could put that trauma team, define that trauma team at the beginning of a shift, however many people that team is.
Okay. Thank you. So we have one more question from online from Ali Haidar from Indonesia. He said, "Hi, Professor McNally. Please share with us the pre-hospital trauma team assessment approach you would recommend to be used by the MS."
Oh, wow. That's a great question. I don't know if I have enough time to go through that, but I think, a lot of the training that we've been talking about more today is more hospital approach. BTLS is a good curriculum. And I think there's others examples out there, but you need to basically, depending on EMS in certain communities may be volunteers. Other places it may be, paramedics, that are paid and professionals. You may have a wide variation. I think you need to look at in your system, what is the scope of practice that your service can provide for? In other words, if you're having volunteers and they're going to be doing basic first aid, that's what the training and the approach to that patient should focus on. If it's a higher level of care, then, being able to do like a BTLS course, that I think would be a good start in terms of your initial assessment and management. There's plenty of examples out there. There's not, I think, one course or one curriculum, but it should, whatever that curriculum is, it should meet the needs of your providers, and, make sure there's a match.
Okay, so another question from Dr. Wei Ming. Do you think pre-hospital trauma life support or PHDLS is adequate for EMS trauma training?
I think it's definitely a course to consider if there's resources that allow for it, right? Certain communities don't have the ability to implement a course, but if they do, I think it is a good course. I don't want to think I'm endorsing one course over the other, but I think there are good examples out there. And again, like I mentioned, ATLS, that's an, American College of Surgeons. There's, Japanese have their own course. There's a lot of other courses out there. The idea is you find a curriculum that's going to meet your needs and you try to train broadly. So when you come into work that day, regardless of who's the team, they have a basic understanding of a team approach to managing, even if it's a team of two.
Okay, so we ran out of question now. So we're going to move to the next session.